to welcome everyone to Concurrent Session 8, Digital Innovations in Healthcare, or in Care. My name is Peter Varga. I'm the Chief Clinical Executive with HealthHub Patient Engagement Solutions. For those who don't know, HealthHub is a Canadian company with over 50 years of experience working within hospitals and patients across Canada. HealthHub is an industry leader in providing innovative digital solutions that help to increase operational efficiencies and engage patients at the bedside and beyond. To HealthHub, digital innovations in care means that the patient and provider experience remains a core element to our products and our service delivery, while technology to enable integration and alignment across health ecosystems. So we're thrilled to be sponsoring the eHealth 2022. This session is comprised of 4 rapid fire style presentations. If we have time for questions, we will address those at the end of all the presentations. You are also encouraged to connect with the speakers after the session via the virtual event platform. First up, we have Stephanie Williams, Surgical Applications Engineer with Techna. Stephanie?
Thank you. Good afternoon. Thank you for having me. My name is Stephanie, and I was part of the development team with Techna working to facilitate healthcare anywhere by creating a dashboard in collaboration with Sprott Surgery, enabling the coordination of interdisciplinary health virtually. Prior to COVID-19, the pre-admission clinics at the University Health Network prepared a patient for surgery via an in-person pre-surgical consult. The general patient flow through the clinic started with the patient being checked in by the registration clerk, followed by a consult provided by a pharmacist, a nurse, and an anesthesiologist who complete and sign off the patient's appointment. Due to the pandemic, the pre-admission clinics at the Toronto General Hospital and the Toronto Western Hospital had to pivot to deliver care virtually to keep both staff and patients safe. This introduced multiple challenges providing the same quality of care. The first challenge was accommodating the numerous interdisciplinary care providers which patients interact during the pre-admission appointment. There are multiple staff members within each clinical group, some of whom rotate their time in and out of clinic. With some care providers working from home, the second challenge was improving staff's visibility into the real-time status of the patient's pre-admission appointment, as well as the preceding care provider's patient appointment status to optimize the appointment duration and maintain clinic flow. The final challenge was communication between clinicians. Without all clinicians working in clinic full-time, staff required a central communication system to share appointment-specific information and requirements such as patients being hard of hearing or family member assisting with the appointment. From this change, the pre-admission clinic team conceptualized the idea of PAC-DASH and to try and continue to provide excellent care to their patients. Developers at Techna from the University Health Network were then engaged for a co-development project with Sprott Surgery. With the need of a rapid implementation, it was crucial to reach out to various groups early to make sure that the dashboard's functionality aligned with clinic flow, institutional requirements. I think I'm a slide ahead here. If somebody could put me a slide back, that'd be great. Perfect, thank you. With the need of rapid implementation, it was crucial to reach out to various groups early to make sure the dashboard's functionality aligned with the clinic's flow, institutional requirements, as well as data availability and governance to make sure they would all be able to accommodate the very short 3-month timeline for this project. When working with patient health information, it is vital that it is handled in an appropriate and safe manner. This, though, provided challenges in the development of PAC-DASH. The first was gaining access to the patient health information database. To start, deciphering what information was available, as well as how to access the data, was challenging as the testing database and server were not structured or populated as duplicates to the productions, nor was the production database matching industry standards. There were also barriers regarding functionality. Strict regulations governed our access to the live patient database, and we had to set out clear server requests to be reviewed by the hospital's privacy and security team, which limited the frequency in which we updated incoming patient data. Data visibility retention was also reduced to 3 months of the current date, and the dashboard's communication functionality had to be limited to appointment-specific information, such as needs for translation services or appointment time changes, and could not contain any patient health information. In addition to facilitating care, this tool was built with the intention of facilitating remote consults. This required our team to put in a request for many clinic staff to gain VPN access on remote computers. With COVID, standards and regulations change frequently to adjust to the new information being provided to the hospitals. Though VPN access was initially granted to the clinics, a few months later, upon review, having many clinic staff members with VPN access was considered a security risk. Challenges our group faced from the design perspective included issues such as variability in both sites' flow and staffing, as well as computer literacy. Due to continuous rotations of anesthesiologists in and out of clinic, it took a long time for all anesthesiologists to cycle through and get adjusted to this new flow and consistently use the tool after implementation. Making individualized features for each site also created complexity to the development and maintenance of the dashboard, and additional tools were put in place to facilitate implementation, such as manually adding shortcuts to each staff member's computers, as well as developing additional pointers based off staff computer literacy. When developing and implementing a new tool into healthcare within such a short time span, all the barriers that you face are experienced and need to be resolved within that short time span as well. Many barriers, though, are surmountable with strong and continuous institutional and clinical engagement and communication. The key to the dashboard's success was due to the clinical collaboration, engagement, and enthusiasm shared hand in hand with the development team. Additionally, it was crucial that we had a complete firsthand understanding of the staff and clinical operation. This started with the development team spending 2 days in each clinic shadowing staff to do thorough environmental scans. This included creating and reviewing detailed process maps as well as user stories with clinical leads to better understand and later satisfy the need of the end user. We also gathered additional information and feedback from a group of clinical champions at bi-weekly meetings, including reviewing mock-ups, prototypes, and functionality to make sure that it aligned with the need of each clinic. Right before launching, we carried out user acceptance testing to ensure staff members from all clinical roles found the dashboard intuitive to use and value-adding for patients' pre-admission appointment. The feedback from clinical staff was very positive, and they were excited for PACDash's rollout as they, the end user, had been the focus from the beginning. In addition to the strong clinical collaboration, PACDash's smooth implementation into clinic is owing to the multiple live training sessions that were held by the development team, the individualized staff tip sheets provided, as well as our on-site clinical support the week of the launch. We continued to meet with the clinical champions after go live to ensure the best support and receive feedback. This led to 3 additional releases and iterations to the dashboard to seamlessly support and augment clinical flow. After all this hard work by both the pre-admission clinics and the development team, a post-implementation survey concluded that staff found the dashboard intuitive, accurate, relevant, and well integrated into the clinic's flow, and were using the dashboard to facilitate the patient appointments. In addition to the staff satisfaction, patients reported that their virtual care experience was efficient and the clinical provider's communication was excellent. In a 3-month window, we were able to go from ideation to implementation and create care anywhere, with the dashboard coordinating interdisciplinary care virtually for the pre-admission clinics. Thank you very much.
Thank you, Stephanie. I would now like to invite Chelsea Stunden, Manager of Research and Evaluation for BCCH Digital Lab, to present. Stephanie?
Hi, everyone. My name is Chelsea. Do I have access now? Not yet. Well, thanks for the lovely introduction. My name is Chelsea. I'm a Manager of Research and Evaluation at the Digital Lab. We're an integrated unit of the University of British Columbia's Department of Pediatrics and also BC Children's Hospital. And our goal is to improve the lives of children and family through digital innovation and technology. So today I'll be presenting on the development and testing of a pediatric digital seizure action plan, which we created in partnership with the Division of Neurology. Specifically, shout outs to Dr. Michelle Chu and Dr. Mary Connolly, also the head of the Digital Lab, John Jacob, who this project wouldn't be possible without. And before I go forward, I just want to give a little background in terms of the condition that we were creating this mobile app for. So there's a type of seizure called status epilepticus, which basically refers to prolonged seizures or multiple reoccurring seizures without return to neurological baseline. And this is one of the most common pediatric neurological emergencies, that was a tongue twister, in pediatrics. And It's really important that there's timely administration of rescue medications in the community in order to assure that there aren't adverse outcomes. Specifically, there can be brain damage or even death. And currently in the setting, what caregivers will, or what the care staff will do is create a seizure action plan in order to support the caregivers in responding appropriately to a seizure when it happens in the community. And typically includes things like what does a seizure look like, what types of rescue medications need to be administered, how do you administer them, how much, and at what time. But unfortunately, we're still seeing that patients are coming into the emergency department, they're underdosed, they're not effectively dosed at the right time, and this is leading to adverse outcomes. And so when we talked to patients and families and caregivers at the hospital, they had mentioned that they really wanted a digital version of the seizure action plan because right now it's on paper, it's hard to access. And so that is kind of the background of how this project came to be. I still don't have access to the presentation, so I can't move forward. Oh, here we go. Okay, so as you can see here, we have the prototype of the digital seizure action plan, which is a mobile application. On the left side of the screen, you can see the mock-up of the clinician portal, which is where the clinical care team puts in information about the patient's seizure action plan. So they'll log in, there'll be a patient database. You can enter a new patient, or you can search for prior patients that have already been entered into the database. There's also a number of details that you can input into the database. Patient details, for example, the weight of the patient, their date of birth, different types of seizures that they have. Then importantly, their seizure action plan, what to do in the case of a seizure. We also had a spot to put the clinical care team members. So who is on their clinical care team if you need to reach out to them to contact them in the case of an emergency. And also we had an audit log, which we have here as patient log, which essentially just documents who has made changes to that plan and what changes they have made. And then because there's only a select number of medications that are used for rescue medications in pediatrics, we also created a medication database, and that allowed us to create some extra fancy features in terms of, for example, checking that the dosages were input correctly and putting warnings in if it was outside the clinical limits that were recommended. And then on the right-hand side, you can see that we have the what the patient would see. So we had made it so that it was really clear which step that the patients were on or the caregivers were on when responding to the seizure. It included key information in bold, so you can see that the dosage and the medication and also the route of administration are bolded, and we hope to minimize confusion with that information. And then at the bottom, you can see we have a visual step indicator that shows the user of the app or the caregiver who's responding to the seizure, what step of the seizure action plan they're on, how many steps they've already completed, and any number of steps that are required, again, afterwards. Can we go to the next slide, please? Thank you. All right, so there were some key tasks that we wanted to accomplish with this mobile application based on talking to the patients as well as the clinical care staff. So there were 6 of them that we really wanted to make sure that we were hammering home. So number 1 was that we wanted people to be able to locate the seizure action plan. We also wanted people to be able to identify who the patient was and what their information was, any key information that the clinical care team thought was important. As well, we wanted the caregivers to be able to administer the correct medication and dosage. And in order to do that, they need to be able to find the medication and the dosage appropriately. We also wanted them to be able to identify the patient's clinical care team if they needed. We wanted them to be able to save the plan for offline access in the case that they didn't have data or Wi-Fi service where they were accessing it. Also, we needed a way to share the plan because the parents or the caregivers of the patient might not always be the ones who are responding to the seizure in the community. It could be teachers or daycare or other folks. So we needed a way for parents to be able to share that with whoever was going to be caring for the kids. And in order to test these things, we ran the app or the prototype through a number of user tests. Specifically, we asked people to run through a series of tasks and scenarios, and then we timed them on how fast they were able to do it. We measured how accurate they were able to do these tasks. And then we also asked them for feedback on how satisfied they were with how we had set it up in order to complete these tasks, and if they had any feedback for us. Next slide, please. All right, so you can see we just have like a small handful of people because this was a first iteration of our prototype. And so on the parents and guardians, generally people were quite pleased with the app, but they did have some feedback for us. Some things that I want to highlight that might be helpful for other people who are creating apps in pediatrics are there was a difference for parents and guardians in terms of the performed actions versus the prescribed actions. And so they commented that often in emergency situation, they might not actually follow the actual prescribed actions. And so they wanted a place in order to indicate what they had actually done versus what was prescribed. And we didn't have that in our initial prototype. Another thing they mentioned was they wanted step-by-step guides. So particularly in the case of people who weren't super familiar with responding to the seizures, they didn't know what it meant when we said like a buccal administration or like in the nose or like something like that. Like they wanted a step-by-step guide of what that actually looked like and how to do it. And then lastly, we interestingly forgot to add emergency contacts. So the kids, obviously the parents of the kids, if they're going to the hospital, want to be contacted if that's happening. And so they wanted a spot for that in the patient portal as well. People wanted more information about what they would have to give to the emergency responders when they show up at scene, as well as what they might need to bring to the hospital. And then we tested the clinician portal with the neurology staff. And something that was really interesting that came out of the testing was that the neurology staff made a number of comments on the legitimacy of the app because of certain programmings that we had made in terms of specifically adding the dosage related to specific medications. So for example, if they were able to add more like a very high dosage of a specific drug, for example, midazolam, and it wasn't actually clinically indicated and they were still allowed to do it, they didn't see the app as very legitimate and they really didn't like that. And so that was really interesting and why we implemented some of the safeties in the back end in terms of setting notifications if it was over the clinically acceptable limit. Also, they wanted prompts for connecting data. So specifically, we had the audit log, but the doctors on the case, the neurologists, wanted to be prompted if, for example, a nurse had changed something in the seizure action plan. And that actually happens a lot in pediatrics because the weight of the kids is changing quite often and the dosage has to accommodate for different weights. And so they're changing the seizure action plans quite frequently. And so the doctors wanted to be aware of that. They also wanted to prompt the patient if they had changed something in the seizure action plan so that they would know that there had been an update. The other thing that people brought up was that we had set it up so that they would search for patients by name if they'd already been entered into the system. And doctors really didn't like that. They said that there's lots of people with similar names, and so it would be really hard to find their patient. It wasn't very user-friendly, and so they preferred searching by MRN or PHN or something like that. And then lastly, they wanted to have more customization because there's so many different types of seizure action, or seizures, and also status epilepticus. And so they really wanted to have, for example, an option to put in 2 different types of seizure action plans depending on the seizure presentation. All right, so I'm out of time, it seems, so I will wrap up there. And thank you. Let me know if you have any questions.
Thank you, Chelsea. Quickly, we'll move on now to Dr. Helen Goldbloom, Children's Hospital of Eastern Ontario. Dr. Goldbloom. I think you're still on mute.
Yeah, I think I just need control of my slides or advancing. Can someone advance? There we go. Okay. I don't have control yet. Can someone go to the next slide, please? Perfect. Thanks so much. So thanks so much for the opportunity to talk about our patient portal. We use MyChart at CHIO, which is linked to our electronic health record. Oops. Can we go back to the first slide? There we go, which is linked to our electronic health record EPIC. And it was a clear choice for us to move forward with using a patient portal because we know they can enhance patient engagement, improve quality of care, and certainly are increasingly useful in the virtual care era. However, in the pediatric context, we face unique challenges where we really need to ensure rightful access, especially as it relates to adolescents. And so we turned on our portal in 2016, and the patients and families who were using it loved it, but we had a very careful activation strategy, and so our numbers remained low. So our challenge was really how to promote portal use while protecting patient, particularly adolescent, confidentiality. Okay, next slide. Doesn't seem to be working for me. There we go. So to outline specifically the barriers that we were facing, definitely there was major hesitancy and fear on the part of providers and provider teams, and I know that's not unique for us. So they were worried that patients and families would be very worried if they saw all of this new information, and also that there'd be an onslaught of emails and calls because of all this extra information that they're seeing. Also in Canada, you know, we don't have a clear age at which a youth or adolescent needs to consent to the release of their health information. Instead, it's based on capacity, and capacity is dynamic. And so there's judgment involved here, and that's a difficult rule to follow, even for people who want to follow rules. Also, ensuring rightful access to both patients and proxies is a challenge and a barrier. So we have these private conversations with adolescents, for example. We put that information into the chart. We promise them privacy and confidentiality. We can't then go and be sharing that information via MyChart to the proxies. We also have some very specific examples of high-risk clinical areas where the portal was thought to maybe do more harm than good. So specifically, our eating disorders team was worried that patients being treated would see in the portal their weight climbing, and there is some evidence that that could actually impact their clinical outcomes negatively. Also, with our child and youth protection team, we needed to be particularly careful in terms of who is getting access to clinical information. We also intentionally had a two-step activation process where patients and families apply for MyChart access, but then it's centralized. Oops. Back to the last slide, please. Thanks. Centralized in our health records so that we have very careful activation. And what happens here, though, is although there's a lot of enthusiasm and interest in signing onto the portal during the clinic appointment, let's say, when they actually get the activation code 24 hours later, that enthusiasm is gone and they're on to the next thing. And so we lose potential participants. Also, we intentionally made a decision to have all or nothing MyChart access. So our patient access is the same as proxy access. They see all the same things. That's different than the approach that a lot of American hospitals have used, where proxy access, once the patient is 13 or 14 years old, it's very limited. Maybe all they see is past and future appointments, and that's to protect these breaches. But for us, it was very important that if the proxy was going to be involved, that they saw useful information. So we needed to be particularly careful that the access they were getting was rightful. And then in the virtual context, you know, not having MyChart access was an additional barrier because of all the pre and post clinical encounter information exchange that happens to support care. So to the next slide, please. So in terms of our solution, it was really a multi-pronged solution. We have a multidisciplinary, stakeholder-rich MyChart leadership group with excellent patient and family engagement, and it's embedded within our hospital governance structure, and that really guides all of our patient portal decisions. When we went live, we piloted within a few specific areas and did formal evaluation, and lessons learned really guided how we expanded and what functionality we allowed. We made sure that our age thresholds for which a youth needs to consent for the release of their own health information is aligned, whether it's via patient portal information release or formal release of health information through our health records. So we chose an age of 12 at which a youth must consent for the release of their own health information. Of course, there are exceptions, and I will get to that. We also maintained a primarily central processing of applications so that all of our activations go through health records and then are approved, but we really resourced our health records so that that turnover time could be shortened and that there was a lot of support there. We also developed standard work to ensure that exceptions to the rule, for example, the 14-year-old who has a medical diagnosis that makes them incapable of consenting to the release of their own health information, that there's a clear process for providers and families to get through that, and then their chart is flagged so that rightful access is maintained. We've turned on instant activation in some low-risk contexts. And we use clinic-specific hooks to promote utility of MyChart. So for example, a clinic where, for example, our COVID assessment center, we really promoted MyChart there because a hook is getting your COVID-19 result. And so if we can really promote activation there, we get more patients on the portal. We also regularly evaluate our patient and family experience, and that really guides our work plans and functionality. And also we focus on provider education as we've had evaluation that's identified some gaps there. In terms of our results, we currently have over 90,000 patients on our portal, but that's just unique patients. So each patient has one or more proxies sometimes, so that's many more accounts. But I think the most important stat is that 40% of our active patients, so those with an appointment within the last 6 months, are live on the portal. And actually in many clinics, it's up to 70 and 80%. So it's really meaningful use. We exchange several secure messages between families and care teams each month, and we have extremely rare privacy breaches. Just to highlight some of the patient and family experience, 93% tell us that the portal helps provide better care. 88% tell us it helps to better understand their care. And importantly, which we fed back to provider teams, 78% of them say it helps avoiding a call to clinic. And that is my final slide. And I think the last slide is just how to connect with me if you have questions.
Excellent. Thank you very much, Ellen. Our final presentation of the session is brought to you by Wenxiao Ma, a PhD student from Research Institute of McGill University Health Center. Wenxiao?
Yep. Hi, I'm Wenxiao, and currently a PhD student at Research Institute of McGill University Health Center. I don't have access to my presentation yet. Okay, it's moving. So yeah, I'm going to present the project. So Enchanté Marvin, development of a chatbot for HIV patients using participatory design. And yeah, so a little bit of context, after 40 years of the HIV pandemic, still no cure or vaccines exist, but effective antiretroviral therapies have significantly improved the life expectancy of people living with HIV. However, to this day, they still require lifelong monitoring and follow-up, and also adherence to treatment to maintain an undetectable HIV viral load, and therefore avoid complications and transmitting the virus to others. And also now with the antiretroviral therapy, HIV is now treated as chronic conditions. So that means patient self-management is essential to optimize health outcomes. And with this, there are two elements, important elements to ensure a good quality of self-management. So first of all, timely and validated information from reliable resources, and also patient engagement in care. And with the arrival of the COVID-19 pandemic, these needs were highlighted. So that's why our team has this motivation to develop a chatbot to support our patients. And a chatbot is a artificial intelligence-based techniques that can mimic human interactions and converse with users using natural language and answer their questions. Yeah. So with a multidisciplinary team, we have patients and healthcare professionals, engineers, developers, and also researchers in the team. Following a participatory design approach, we started this project at the beginning of 2020. And then after 8 months, we got our first prototype completed. We named it Marvin, representing minimum antiretroviral interference. And here's an example of how the algorithm works. First, it receives input messages, and then it will try to understand, the algorithm will try to understand the intention behind the messages, and then also extract the important entities as the context, and then it will send out the answers associated to the messages. So with the first prototype, we then do a lot of improvement through several rounds of testing with our expert groups. So first of all, with our patients, we collect a different formulation of certain topics. For example, here I was late for my medications. All these resources data were used to train the algorithm and make it more robust and to understand well the messages. And here again, exchanges between the devs and healthcare team to elaborate the more concrete answers and also build more valuable information to distribute to our patients. So then with a solid prototype, we decided to run a pilot usability test. Last year, we did it with 28 participants at McGill University Health Center in Montreal, Quebec. And we have presented our preliminary results at ESCS European AIDS Conference last year, and also this year, qualitative detailed results at CAR 2022. And basically, it showed that the chatbot is usable and acceptable from the point of view of our participants. Here are some citations from the qualitative interviews. So they think that Marvin is easy to use and convivial to chat with. It is easy, it's like talking to a friend on Messenger, and also participants were satisfied with their experience. So I would like to say from 1 to 10, now it's an 8 given stage of development because it's on the right track. And they also find it useful and helpful as a technology. You ask the question and answers you on the spot for the most important ones, and also concerning the medicines too. And for the future, they said they would use it, especially if it were more informed. So they are expecting more topics like diet, nutrition, exercise, and research. So all of this will be appreciated in the future. So then December last year, we officially launched the trial service to the public on Messenger across Canada. And now it's working 24 hours, 7 days on Messenger. And yeah, it can converse with users in both English and French. We use Amazon Web Service to deploy our cloud services, and also Reza as a chatbot design framework. We use it to develop our chatbot. So here I'm going to show you a quick demonstration how we can converse with Marvin. Hi, hey, how are you? Great. Can I ask you a question? Feel free to ask me any questions. What does undetectable mean? A basic question for HIV knowledge. So undetectable means there are a few copies. Why are you asking this? Are you concerned about your health status? No, not really, just curious. Good to know. Another follow-up answer. Thanks, you're welcome. Another question, I have a PO, but I don't know what it is. What are the letters and numbers written on a PO? 227, good one. This one is interest. A picture just to confirm, does it look like this? Yeah, thanks. My pleasure. So you can see it's quite straightforward to talk to Marvin. And also we support different types of messages like pictures, and also video link is possible to support our answers. So yeah. To conclude, Marvin is usable and acceptable to people with HIV given the stage of development, and it's quite promising as a telehealth tool to support patient self-management. And for the next phase, we are aiming to add more topics on various healthy practices, and also try to improve Marvin's intelligence and the concept of personalized wellness companion. So basically, we will put more artificial intelligence into the decision-making parts. For example, triage is our idea, and also detection of potential problems, and also make Marvin more proactive. That's all for my presentation. Thanks.
Thank you, Wanchao, and to each of our presenters for such an interesting presentation today. Next, I'd like to invite all of you to attend our exhibitors for networking and discussions in the virtual showroom or trade room. Your access is available at the top of the screen. So thank you everyone for joining us here today, and we hope to see you there. Take care.